Fantastic. So now it's 8:03 Eastern Time. So thank you everyone for joining. My name is Dr. Chi-Ming Cha. I'm the Echo Lab Director at St. Michael's Hospital, and also currently in Quebec City, attending the Canadian Cardiovascular Congress, where there's a lot of Canadian Society Echo events as well. So today we truly have a great honor of inviting a guest speaker from Massachusetts General and Brigham, Dr. Julia Grapsa, who is a associate physician specialized in vascular and valvular heart disease and echocardiography. She's a director for education in echocardiography at Brigham and Women's Hospital and faculty staff for Harvard Medical School. She's the founding editor-in-chief for JACC Case Reports under the American College of Cardiology. She is now deputy editor for EHJ Cardiovascular Imaging and senior editor for EHJ Imaging Methods and Practice and Valvular Structural Heart Disease. She won 2012 ESC Young Investigator Award in Pulmonary Hypertension and 2008 ESC Research Grant. She was the first author of the British Guidelines for Echo in Pulmonary Hypertension, and most recently a co-author for the American Society Echo Right Heart Guidelines. And this is a topic she's going to share with us. And with great honor, I want to introduce Dr. Julia Grapsa. Thank you. Please go ahead.
Thank you so much. It's such a great honor to be here with you. As I said before, I've been to Canada. I love Canadian colleagues. Actually, I keep long-term friendships with our colleagues and from Canada. So I will speak today about the right heart, and practically I will go through anatomy and physiology, and then echocardiography 3D strain, and I will delve into the 2025 ASE guidelines, and I will speak a little bit about, I will touch a little bit structural interventions. So practically, you know, I was working for many years in the field of pulmonary hypertension, and the main ambition is we used to see patients arriving to us at a very delayed stage, that the right ventricle becomes dilated, pressure loaded, and really fails. And there is a honeymoon period that there are symptoms, and there are right ventricular remodeling has not yet taken place. What we call, as I will show you now, the time of coupling, and then of course the time of uncoupling. But now still there are more advanced therapies, and even when you are talking about clear precapillary pulmonary hypertension, or when we're talking about postcapillary and tricuspid interventions, then the right ventricular assessment is always a hot topic. So when it comes to RV anatomy and physiology, practically the right ventricle divides into the inlet, the trabeculate apical myocardium, and the outlet. And you will see that for the inlet, we have the tricuspid valve, the chorda tendina, and the papillary muscles. It needs to be mentioned that when it comes to the shape of tricuspid regurgitation, and when we assess in conjunction with the right ventricle, you will see very often the definition of ventricular versus atrial. And this has to do with the remodeling. But I will show you later in more detail about the right ventricle, that practically if we have ventricular tricuspid regurgitation, this comes because the right ventricle dilates and then gets hypertrophied, and then there is a component of pressure overload. And usually you will see significantly raised pulmonary pressures, more than 50 millimeters per mercury. While actually in these patients, that's a very big population with chronic atrial fibrillation. They will develop atrial secondary tricuspid regurgitation, which is coming from the dilatation of the right atrium. Usually we have severe biatrial dilatation, and therefore then tricuspid regurgitation is being created, and usually the pulmonary systolic pressure will be normal or slightly elevated. I will speak later about the way that tricuspid is remodeling, but I would like to mention a few more features of the right ventricular physiology, because it's very important to the assessment. So in order to assess the right ventricle, it's important to remember the differences about the right ventricular physiology when comparing to the left. It's a highly trabeculate cavity. It has the septoparietal trabeculation and also the moderator band that practically sometimes many people when they start doing echoes, they confuse that and they consider it like hypertrophy, or even we had here the RV thrombus. Practically, it's a moderator band and it can get hypertrophied in cases of pulmonary hypertension or, of course, in elderly patients. And it's a low pressure circulation. We know that the pressures on the right side, they're hovering around 25 millimeters per mercury, and any acute changes in the afterload will lead to major changes in RV pressure volume relationship. That's why, and when we speak about acute pulmonary embolism, you will see that the right ventricle will acutely dilate, get impaired, and then with the right treatment, it will go back to normal shape. So always we keep in mind the RV pressure volume relationship, the influence of the mechanical work of breathing, and also that the right ventricle is together with the left. So, and this is why we always consider the right when it comes to left ventricular pathology. But it is now well known, and you will see this wonderful review from Becky Hahn in 2023, that the normal RV contracts by three separate mechanisms: the longitudinal fibers, then the movement of the free wall towards the septum, and then the traction of the free wall at the points of the attachment to the LV. Now, a very important part of the right ventricular physiology is that it cannot really cope, the RV, with the sudden increase of the pulmonary arterial pressure. And that's why many times when it exceeds the 60 millimeters per mercury, then we may see that there is acute RV dilatation and circulatory collapse. Then when it comes to the stages of remodeling, you will see that what we have noticed is that there is a normal stage, then the right ventricle starts getting compensated, is the time that still there is some RV-PA coupling, and then when there is transition to the remodeling and practically the RV gets dilated, impaired, then we start getting uncoupling, and then the next step would be failure and ultimately death. Coupling is a very important entity, and when someone is assessing RV or, of course, again TR, they need to understand that when we have what we call uncoupling, then the RV contractility gets impaired. Then the RV can no longer compensate for the increase in afterload, and we have eventually significant RV remodeling. It's at the time point that the RV is failing, and therefore the RV, when it gets impaired, maybe we will lose a very important time, a very important window that the patient is amenable for therapies, whether these therapies are medical therapies when it comes to pulmonary hypertension precapillary, or when it comes to structural interventions. We want to preserve the function of the right ventricle and, of course, the coupling. It has been proven that even for structural interventions, it seems that the RV-PA coupling is associated with outcomes. And practically, when if you will see here that when when there was significant uncoupling, less than 0.4, practically there was an observation that the all-cause mortality increased, and there was no RV afterload reserve. And of course, it's what we call a significant degree of uncoupling, and therefore that these patients would have bad outcomes after tricuspid interventions. Now, tricuspid annulus is very important. What we did is in 2012, we did the first studies of studying the tricuspid annulus in relation to the tricuspid leaflets. And we saw practically that there was a significant impairment when it comes to different physiology of the right ventricle. So a different pulmonary hypertension etiology will actually affect differently the RV remodeling, and therefore it would affect primarily the tricuspid leaflet mobility. And you would see that when it comes to left ventricular pathology, we would have almost normal tricuspid valve, but when we had pulmonary arterial hypertension, practically the tricuspid leaflet tethering would be quite, leaflet movement would be quite impaired. And this is later what led us to, in 2015, to work with Dr. Levine and Dr. Picard to develop a model for tricuspid leaflet excursion that I will show you later. But based on the physiology of RV remodeling, you will see that, for example, in pulmonary arterial hypertension, we would have significant increase of RV volume, significant decrease of the RV ejection fraction, especially in end stages, and the RV gets hypertrophied until it comes this point that the RV fails, and practically we will have a regression of RV mass. That was actually the topic of my PhD. And then the regression of RV mass, it will get associated with the outcomes of death. But in pulmonary arterial hypertension, we'll have also significant increase of the RVSP and significant increase of pulmonary vascular resistance. And of course, the capillary wedge pressure will be normal. When it comes to the other side, the post-capillary pulmonary hypertension, you will see that gives you an RV that is close to normal size or mildly dilated. And of course, pulmonary pressures are raised, but they're never raised more than 50, 60 millimeters per mercury. So in pure post-capillary pulmonary hypertension, we will have moderate pulmonary hypertension and not severe. Now, how do we assess the RV? First and most important is practically the qualitative assessment. And what we are doing, um, we see first the right ventricle, and we try to decide whether it's a volume overload, whether it's pressure overload, and of course, whether it's a combination of pressure and volume overload. What does it mean? That if we have volume overload, it could be, for example, severe tricuspid regurgitation or severe pulmonary regurgitation. Let's give an example that you will not have much hypertrophy, but you will have significant dilatation of the RV, and the contractility will be still preserved, or, for example, will be slightly like mildly reduced impairment of the RV. The tricuspid annular dilatation, as we have shown in atrial functional tricuspid regurgitation, will get dilated, and of course, TAPSE, because of the volume overload, will be sometimes pseudonormalized. But when it comes to pure pressure overload, you will see significantly dilated RV, then significantly hypertrophied, that of course it has impaired contractility, and the TAPSE will be definitely reduced. But it's difficult when we have advanced stages of pulmonary hypertension, that you will see a dilated RV with significant tricuspid regurgitation, then it's a mixed picture between pressure and volume overload. Here, for example, is an example of a patient of mine that he came with this advanced degree of pulmonary hypertension, and while we were doing the workup, unfortunately, he had VF arrest, and he died on the floor. But you can see very distinctly that the RV is significantly dilated, that squeezes, it creates this D shape of the left ventricle. The eccentricity index is impaired. And then, of course, we have dilatation of the right ventricle, significant hypertrophy, impairment, and it's this known pericardial effusion around the right atrium, which is coming from the increased right atrial pressure, which is very important actually as prognostic for death. Now, in the assessment of RV, it is important to understand which factors can be prognostic, practically to indicate that if you have an impaired index, that will be indicating bad outcomes, such as, for example, the outcome of death or right heart hospitalization because of right side heart failure, and which of them are purely diagnostic, meaning to set the diagnosis of pulmonary hypertension, such as right ventricular systolic pressure, of course, TAPSE, or fractional area change. While, for example, they are very important, they have not been traditionally related to the outcomes of death or hospitalization, and the same with eccentricity index. Well, if you see, number one is the significance of the tricuspid regurgitation. If a patient has severe tricuspid regurgitation, as I will show you later, that's quite indicative of bad outcomes. When it comes to RVOT acceleration time, then you will see that we practically measure it from it's another marker of significant increase of pulmonary pressures. And you will see that when we have pulmonary hypertension, then the right ventricular acceleration time is decreasing. For example, here we have tricuspid regurgitant velocity 2.1, and it's normal 160. But then as as the pulmonary pressures increase, that will get reduced until it reaches this pulmonary systolic notch, which is indicative of raised pulmonary vascular resistance. And practically, we know that while it's quite significant in diagnosing raised pulmonary pressures when it's significantly reduced, the pulmonary systolic notch is also associated with the right heart catheterization, pulmonary vascular resistance, and therefore it has a prognostic value. But in the latest ASE guidelines, what we discussed is also that the right ventricular outflow tract velocity time integral is very important when it's less than 18 millimeters. Actually, sorry, 18 centimeters is called, that it will give you an impaired relaxation of the right ventricle. And it's indicative, the profile of the VTI is indicative advanced pulmonary vascular disease and elevate afterload. As you will see, here is the normal shape, and then as the pulmonary pressures increase, this will get more steep. Then the pulmonary systolic notch is getting developed, what we call the W sign in the guidelines, and then it gets quite spiked signal, which is in the end stages of pulmonary hypertension, that you will see a decrease also in right ventricular systolic performance. How about TAPSE? TAPSE, traditionally, it has been used in a lot of studies, but remember always that while you can use it in a pressure-loaded right ventricle, practically in certain cases, while it can be diagnostic, definitely is not prognostic. And when it comes to volume overloaded, remember that because it's very load dependent, then you will have a pseudonormalization of TAPSE. These are two cases of mine many years back, that this was a 31-year-old lady that with idiopathic pulmonary arterial hypertension present with syncope outside the shop with her 6-month-old baby, and she had purely pressure-loaded RV. And here is one of my, within the first year of me learning echo, I did the scan on this 28-year-old lady with persistent shortness of breath. And my mentor at the time, Professor Nikoyanopoulos, he saw the TAPSE that was 30, and he said, and he saw mildly dilated and a bit sluggish right ventricle, and he said, we need to bring this lady back for a bubble study. And I said, you know why? Because he said that something is off here, and I'm suspecting a shunt. And indeed, we brought back the patient, and she had a sinus venosus defect, and that's why, for example, the TAPSE was 30 millimeters. So paradoxically increased and of course the right ventricle was slightly dilated, that would make you think that there was a shunt. So, but make sure that while TAPSE has been traditionally correlate with RV ejection fraction, as I said, it's not correlate with outcomes, and make sure that technically you are measuring it correctly, and of course make sure that you understand that the major limitation is load dependency. Now, we use also the myocardial performance index when it comes to quantitation of our right ventricular assessment. And practically here from the TDI, we can get the isovolumic relaxation time. We can get the isovolumic relaxation time is here, the isovolumic contraction time and the ejection time. And practically, when you have a prolonged relaxation of the right ventricle, that indicates it's actually the first parameter in the pulmonary hypertension assessment that can get impaired when it comes even in early stages of pulmonary hypertension. Traditionally, we measure the S wave, and when it's reduced, practically it will show that we have significant impairment of the RV. One of the advantages of the myocardial performance index, which is the isovolumic contraction time plus the isovolumic relaxation time divided to the ejection time, is that it's independent of chamber geometry and it's quite prognostic to outcomes. But remember that it's heart rate and load dependent as well. We mentioned in the guidelines, but of course it's in the context of other parameters. Then when it comes Here in the guidelines, we changed the cutoff to 2.8, and practically the tricuspid, the right ventricular systolic pressure is measured when we have a good signal of tricuspid regurgitation. If you cannot find the right ventricular systolic pressure, that doesn't mean necessarily that the patient doesn't have significant pulmonary hypertension, because in cases of massive or torrential tricuspid regurgitation, possibly the Bernoulli equation cannot be applied, as we see quite frequently in tricuspid structural interventions when we have torrential tricuspid regurgitation. But if you have a great signal, then the tip of the signal will indicate the peak gradient across the tricuspid valve, and of course, then the degree of right ventricular systolic pressure. And another parameter which is very important, and we have multiple ways to assess that, is actually the right atrial size, which is quite prognostic in right ventricular failure. And we use two-dimensional assessment and three-dimensional assessment. And here is the picture that we've used in the latest ASE guidelines, that practically we use 3D assessment, for example, to measure in centimeter with the volume, the volume of the right atrium, and also from the 2D with summation of discs, or of course using the area length method. But we use also the major dimension and the minor dimension, and we use also the end systolic area of the right atrium in centimeters square. Now, when it comes to eccentricity index, we measure it always at the level of papillary muscles, and we need to make sure that we have the best view of the left ventricle. And we will assess whether we have the D-shaped appearance of the left ventricle, and we know that practically in all normal patients, the eccentricity index at both end systole and end diastole is essentially 1. But when you have a volume overload, practically you will have 1 at end systole, but significantly increased at end diastole. But when you have RV pressure overload, then it will be significantly increased at both end systole and end diastole. So this can give you a first sense of whether the ventricle is pressure overloaded or RV volume overloaded. When in 2015, we did a very important study that practically we took 777 patients with precapillary pulmonary hypertension, and many, as you can see, 500 almost were women. And 25% died within the follow-up, that the follow-up was almost 7 years. And we saw, as I explained earlier, that having significant tricuspid regurgitation, look at the hazard ratio, was 26.5, is #1 factor for bad outcomes. But also we saw good correlation with the RV myocardial performance index. The pericardial effusion is very important, and of course from hemodynamics, the high pulmonary vascular resistance, and of course right atrial pressure. So these proved to be independent predictors of mortality, and it allowed us to create, in a way, a risk score through echo and right heart hemodynamics for these patients with precapillary pulmonary hypertension. And as you can see, on the top is actually the severity of tricuspid regurgitation, and other parameters such as MPI, effusion, pulmonary vascular resistance, the cardiac index, and right atrial pressure. Now, always remember here, that's a mechanical obstruction of the RV. That's when I worked briefly in Abu Dhabi, and there was a patient with lymphoma and infiltrating the right ventricle, and you can see here that has invaded all the RV. And here is, I remember quite vividly this patient, that he had an ICD on, and practically he passed away quite rapidly at the age of 45 through idiopathic pulmonary arterial hypertension. And practically remember when you assess the right ventricle, is important to understand that RVSP is quite dependent on body surface area, and of course age, as demonstrated from this paper McKinnell and Dr. Picard in 2001. And of course make sure that many indices are quite low and heart rate dependent. And this is the difficulty when it comes to right ventricle, that practically when they ask us frequently, is there a single index that can give prognosis in pulmonary hypertensive patients through echo? And the answer is definitely no. And this is what we emphasize, as I will show you in the latest guidelines, that we need a multi-parametric approach. Now, when it comes to 3D echo, we did the first studies in 2005 of comparing 3D echo with MRI, and practically it needs, nowadays we have the automated reconstruction of the right ventricle, that we can even get 3D volumes and ejection fraction and the strain all in one, but practically is based on endocardial mapping. And remember that if you wish to see the RVOT, if you suspect congenital abnormality, practically the selection of choice in regards to imaging is always a cardiac MRI. And practically we used to include the trabeculations into the blood pool, which is another limitation. Endocardial epicardial mapping, then getting the myocardial volume and multiplying to myocardial density gives you the myocardial mass. So we would have the volumes, ejection fraction, and mass, which allowed us actually to do important studies in remodeling and pulmonary hypertension. And we have now optimized, this is the first study that we compared 3D volumes with the MRI, and practically we have new tools. This is from VentriPoint that we use now in congenital patients, or up to deep learning and artificial intelligence that will give us actually the opportunity to get massive data. At the times 20 years ago that we were struggling of here, this is one of the important studies that we did with Jonathan Afilalo, who is in McGill, and practically you will see that it was easier to learn the learning curve and to interpret MRI at the time in 2012 rather than the learning curve and interpreting 3D echo, surprisingly. So someone with 60 MRI scans would have the same learning curve as 120 3D echo scans. And this is because of the technical challenges of the 3D echo. Strain is very important, and it has RV. It gives you a reflection of the RV contractile reserve, either by measuring the global longitudinal strain of the RV or the free wall strain from rest. And sometimes we use also rest and peak exercise that has been included in few studies. And also we have seen used a lot in cardio-oncology, or of course in relation to structural interventions, for example, in post-mitra clip, assessing the RV, or of course when it comes to, this is a patient with cardiomyopathy, and of course, as you can see, reduced global strain and reduced free wall strain. And we use free wall strain because we feel that in a way the global strain is being influenced a little bit by the interventricular septum. Now, we did a study in 2014 that we saw that the area strain, which is practically a global longitudinal strain versus circumferential strain, was prognostic in reflection to the mortality of pulmonary arterial hypertensive patients. So yes, strain is very important. It takes also a learning curve to understand strain and how to interpret strain, but you have the best teachers there in Canada, and of course it's a wonderful tool if you know how to use it appropriately. And I want to mention a little bit the RV contractile reserve, because I feel that has great input in the value of pulmonary hypertensive patients, especially with CPET as well. And also it's a great tool to use in the future for structural interventions and of course the assessment of TR. When we have loss of RV contractile reserve, that also means that this patient, we need to consider seriously whether this patient would benefit from any intervention or any further treatment. So it can help us actually, this exercise-induced increase of the right ventricular systolic pressures, the TAPSI reduction, and also the RV contractile reserve has tremendous benefit, tremendous value in assessing our patients. Now, a brief word that practically when it comes RV, as you can see here, the right side heart failure signs and RV dysfunction And why I'm mentioning this, because it's important to understand how we assess RV, and I will show you also the ASE guidelines, has an important value in triaging our patients. And this is the tri-score that implements RV dysfunction, signs of right side heart failure, and practically it has to do with prognosis after isolate tricuspid surgery. And when it comes to fundamental studies such as the Triluminate, you could also see that tricuspid interventions had a positive influence on the RV volume reduction for these patients that they got a structural intervention on the tricuspid position. And you could see that there was, while the RV has remodeled already from the tricuspid regurgitation, it proved that practically there was a reduction of volumes and improvement of forward flow and effective RV ejection fraction with the cardiac MRI. So this is important. Why? Because we keep discussing about how we would assess appropriately the RV. And here it comes a very crucial slide that practically from the world of structural interventions up to now, we have excluded patients with severe pulmonary hypertension. And why is that? Because it has been proven that when, of course, we have invasive assessment of pulmonary pressures together with echo is more prognostic when comparing to using echo alone. And it showed that practically it's when we have raised pulmonary pressures, it's there is no point actually to help the patient any further. When, for example, we have a mixture of pre and post capillary components, we need to, and for it's immediately relate to the outcome of death, heart failure, hospitalization, or reintervention because the right ventricle cannot cope. So when we assess a patient with significant tricuspid regurgitation, we need actually to encourage people to have a standardized assessment of the RV, to understand the guidelines and to use them appropriately, and to understand, will this patient benefit from this, or they will not benefit in the long term. This is a very important point. And I mentioned about the TAPSI versus RVSP, this coupling ratio, and of course the demonstration of uncoupling is very important when we assess patients. We use it routinely in our daily basis when we assess patients with echo, and we mention that when it comes to meetings in order to show whether a patient will really benefit from a procedure. Again, I don't want to stay much here because it reflects the 4 types of right ventricular impairment and adaptation. Here it reflects the 3 major types that the RV, type 1 is that the RV preserves its contraction. Then the type 2 type of remodeling is that the RV, when it comes to tricuspid patients, that the RV dilates even further, and there is a first signs of reduction of RV contractility. But type 3 of the RV impairment is when the RV has dilated enough and there is significant volume overload, and of course sometimes pressure overload, and of course there is significant impairment of longitudinal circumferential function. Again, when it comes to these patients that they will benefit or not, when someone has developed a right side impairment, the right heart is failing, and therefore they will develop cardiohepatic or cardiorenal syndromes, then we need to consider quite significantly the effectiveness of these treatments, modern treatments. There is an explosion in the market. That's why we are discussing a lot if the patient will really benefit from that or not. And so we use this assessment in the when we have a meeting. But yesterday we had an interesting journal club from ASE that you can still follow on Twitter about the latest guidelines on assessment for the right heart. These were published almost 6 months ago, and Monica Mukherjee from Johns Hopkins is the first author. Lawrence is together with Monica were the chairs of this document. Lawrence is an exceptional human being, wonderful clinician, and a long-term friend for me. And I own him a lot. I will explain at the end why. But practically, we have here a comprehensive table with all the thresholds and normal reference values that you will see according to all the literature that led up to the writing of this document. Then we used very comprehensive algorithms for determination of right atrial pressure. For example, what we suggest is practically we need to have defined right atrial pressure value in order to have one single measurement for right ventricular systolic pressure. We use 3, 8, 15, or 20, depending on inferior vena cava size and also collapsibility. It's important to use it to understand when to use a focused apical four-chamber view for the right heart. So many times we see that it's foreshortened, especially when the right ventricle is dilated. Then it's very difficult to obtain a non-axis view. But bringing the probe close to the axilla of the patient, you will get a very RV focused view, which may allow you even to do 3D and strain. The importance is practically to see the lateral wall of the RV in order to make sure that you are on axis. Another important parameter is, as you know, you cannot assess the RV from a single view because the RV is behind the sternum, and practically we need to get a multi-parametric approach. Sometimes when the patient is ventilated and you will not have good parasternal views, you may actually there have been when I was scanning a lot, we could do subcostal and practically do the full protocol for the RV from there, from only subcostal views. So make sure, when you practice on your patients, make sure that you see the RV outflow view, the short axis, the apical views. Try to get the RV free wall. Try to get a good subcostal view. These are very important windows. And of course, as I mentioned here, the new guidelines are bringing firm formulas and values for the right atrial pressure. This is a change, for example, 3, 8, 15, and 20. It's a very comprehensive table. So we don't have anymore the range, but we prefer a very definite value, which will allow us to give a precise value for the right ventricular systolic pressure. So I tried actually to give the most important changes on the ASE guidelines when compared to the previous ones, because I want to leave a bit of time for discussion. I know that I have given you a lot of information, and if you have any questions, for the next 20 minutes, I will be at your disposal. In brief, frequently you will see that they ask us about a single parameter for the RV, which is determinant for outcomes or for assessment. There is not a single echo index which is determinant of RV function, but we need in a full protocol, even if it will take you a good 10 minutes to assess the RV and make sure that we do the right risk stratification for our patients and patient selection. It's important to position the patient and get a multi-parametric approach of the RV. And of course, many indices, as I demonstrate, they have load dependency or heart rate technical limitations. So make sure as you go along and measuring the RV, when, for example, to take an index into consideration in the general context together with other indices. And with that, I would like to thank you so much for your attention, and really grateful to you for the invitation, and of course to Dr. Lauren Stratsky today for suggesting me to give this lecture.